Can you guys see that?
Yes, sorry.
Okay. Is it showing in presenter view? I can't tell. If it is, just let me know and I can switch back.
I think it's in presenter.
Oh, it is. It's in presenter mode. It's not in like the regular.
No, yeah, it's just not taking up the full screen.
You can see it now.
Okay, got it. Sorry about I'm not sure why there's like so many difficulties with it, but hopefully you guys can see
It's
now.
okay.
Just let me know if there's any more issues.
Okay.
Um, okay, so as I was sort of saying, it's hard to distinguish true infection from colonization. So they think that around 40% of isolates are not not truly causing infection. So it's important to just be able to distinguish that. There's no standard of care regimen either, which can be kind of hard. Usually for crab, we're kind of throwing anything that says susceptible on the panel. We're kind of like throwing those together to hopefully have a treatment effect. It's a pretty high mortality, so about 25% mortality and very highly drug resistant. So here's just some of the resistance mechanisms. Just for the sake of time, I won't go through all these, but I just wanted to point out that obviously it has a ton of ways that it can develop resistance, mainly through selective pressure when patients are receiving like broad spectrum agents. The most common mechanism for carbapenem resistance is this OXA enzyme that gets produced in about 83% of strains. And that is really the most pertinent thing you need to know about resistance for crab. In terms of treatment approach, so really what the IDSA guidelines recommend for the past two iterations of the MDR gram-negative guidelines is that combination therapy is recommended, at least up front, for a few reasons here. So for one, there's just a lack of good data with any single agent on its own. There's thought to be pretty high bacterial burdens, because as we know, a lot of our empiric regimens don't really cover um, crab up front. So that can lead to a lot of bacteria that's there. So you really need that synergistic bactericidal effect to kill the pathogen. And then agents that may appear active in vitro may develop resistance on treatment. So it's thought that if one of your agents develops resistance on treatment, at least you'll have that other one to back it up there. So as of the 2024 guideline update to the MDR gram-negative guidelines, this was within the past like month or two, I want to say that it was updated. But the preferred combination regimen for crab, for moderate to severe crab, I should say, is now the combination of sulbactam, durlobactam, or Zacduro is the brand name, plus either imipenem, cilastatin, or meropenem. So adding on a carbapenem there. So as we know, we've used sulbactam for years for crab. It's kind of been like the drug of choice. So how it works is that it binds to PBP1 and 3 to kill the organism. And then durlobactam is a beta-lactamase inhibitor that is able to inhibit that OXA23 enzyme that we talked about to really allow the sulbactam to go and bind to the PBPs. The reason that they added the reason they added imipenem in the studies, specifically in the attack study, is so that they could have some polymicrobial action, because Zacduro only really covers one pathogen, and that's crab. So it doesn't really have good empiric activity. So they needed to add on like a carbapenem to get that broad coverage. But there's also some thought, however, that it could have some synergistic effect with the Zacduro as well, which on the next slide, I had an illustration that I really wanted. I was excited to show you guys. I was going to illustrate the mechanism of like how these two are thought to have synergistic activity. But since my slides are being weird, I don't know if my animations are going to show up. But essentially how it works is that this durlobactam here binds to OXA 23. The sulbactam molecules go and bind to the PBPs, and then the carbapenem is able to go bind to that additional PBP2 to have extra killing, they think, of the pathogen. And it also serves as sort of like a substrate for this oxa to sort of distract it to allow more sulbactam to get through. So sorry that that won't work. So quickly, I won't go, for the sake of time, I won't go through this whole study, but this is the big trial that looked at Zacduro. It's actually been the first study to date that has shown a benefit over colistin for crab isolates. As I had said, it combines Zacduro with imipenem versus colistin plus imipenem. How they dose Zacduro is just 1 gram of each every 6 hours over 3 hours versus colistin for both arms receive 7 to 14 days. When they looked at the all-cause 28-day mortality, it was 19% for Zacduro and 32% for the colistin group. And as we would expect, significantly lower nephrotoxicity with Zacduro. So it was able to meet non-inferiority and have a good mortality there. This is just the Kaplan-Meier curves, and just, I'm not sure if you guys can see that very well in this mode, but it almost met superiority for 14-day all-cause mortality. So it seemed to, for whatever reason, it performed very well up front for those patients that were really sick with crab infections, which is pretty interesting. So as of right now, though, even though, the guidelines recommend Zacduro up front, but a lot of us, essentially none of us actually have Zacduro on formulary. However, it is available. We looked it up the other day just to see. It is available on McKesson if we were to ever need to use that. But hopefully, fingers crossed, we won't need to. But in the meantime, until that becomes more like commonplace, the guidelines are still recommending our trusty friend, the high dose unison that we've been using for a while in combination with another agent. So the high doses, as we know, are thought to really saturate the PBPs and overcome the resistance. Even when unison tests resistant, that high dose is thought to overcome that resistance just due to saturation of the PBPs. And how we give the high dose unison is you can either give it 9 grams every 8 hours over 4 hours, or the continuous infusion 27 grams per day. However, that one is in a liter of saline, so probably not as well tolerated, and also deals with stability issues. So we have our order panels within the WV medicine system that will typically use the 9 grams every 8 hours. Here's just some meta-analysis data I won't go through for the sake of time. And then in terms of some of the combination regimen data, here's really there's only 7 RCTs that looked at it. The only one that showed a benefit was one that included high-dose unison, whereas the others were things like colistin plus rifampin, colistin plus meropenem. None of those really showed any significant benefit from the addition of rifampin or meropenem. So that's why the guidelines don't recommend those as adjunctive agents. However, the 2 adjunctive agents that they do recommend that you could possibly add on to the high-dose unison are either the tetracycline derivatives or ceftriaxone. So when you're thinking about the tetracycline derivatives, there's 3 main ones: minocycline, tigecycline, or ribocycline. They do state like preference for minocycline over the others, just due to the fact that we have the PO option, so patients can easily be transitioned to oral therapy. There's the availability of the CLSI breakpoint, so you can know if your pathogen's actually susceptible. However, there has been some recent studies, and the guidelines talk about this, where they recommend to use caution with minocycline MICs in your crab isolates above 1, because with MICs above 1, there's been some not great PK/PD data. So if you are to use minocycline as part of the combination regimen, you definitely want to send that off for susceptibility. And if the MIC is 2 to 4, you may want to consider an alternative. Cefiderocol is another one that they mentioned. So high rates of in vitro susceptibility. However, we don't really feel comfortable using that as monotherapy right now, just due to this credible CR study, which was a large study of a lot of different MDR pathogens. Specifically in the crab arm, though, there was 49% mortality with cefiderocol versus 18% with best available therapy. So just as a recap, here's a algorithm that goes through what our preferred combinations are. Again, first line, they're really recommending that Zacduro plus carbapenem. Alternatives, you can either do high dose unison plus minocycline, cefiderocol, or polymyxin B. So I also had a patient case here. Do we have time to go through this case, or do we need to move on?
Yeah, you still have about like 7 minutes or so, so you're okay.
Okay, perfect. I just wanted to make sure. So this is actually a case that was inspired by a patient that Dr. Orsiga and I had here. He's the infectious diseases doctor at Wheeling Hospital. This is inspired by a patient that we had not too long ago. So this is KV, he's a 60-year-old male with history of peripheral vascular disease, type 2 diabetes, and osteomyelitis of the left foot caused by vancomycin-resistant enterococcus, dapto-MIC of 4. So therefore, he previously had to be treated with high-dose dapto, cefepime, and flagyl for 4 weeks, followed by oral linezolid, Cipro, and flagyl for 2 weeks. And this was all 1 month prior to the present admission. He was admitted to the ED due to increased left foot pain and swelling. A superficial wound culture of the left foot revealed the following culture. So I have that. I included it here on the next slide so you can see, but essentially he's claustrophobic, so we can't obtain an MRI. And there's no plans for further bone debridement this admission. So ultimately, the team decides to treat for a short course of skin and soft tissue infection of 14 days. So, what treatment regimen would you all choose for the crab isolate? Assuming he's already on daptomycin, by the way, for the MRSA, but assuming that you feel the need to treat this isolate, what would you treat with?
Did somebody in the chat say C?
C. Yep, exactly. Does anyone else have like other thoughts, or like would anyone else do anything different, or something that's not even on the slide?
Anybody have any recommendations of what they would do different, maybe?
Was the Staph aureus in the blood or just the bone?
It was just a wound, actually, just like honestly just a superficial wound culture. So
Yeah, I might be to do like do Areva or Taigi plus the high dose Amsilbactam and then get rid of the dapto.
oh yeah, that's actually really smart. Yeah, that would definitely have been an option for sure. Because like you said, it wasn't in the blood. So definitely would have been a good option.
Yeah, I like what Dr. Gilfus mentioned. I mean, these superficial wound cultures can get you in a little bit of a tough situation where you're isolating, bacteria in the foot or bacteria around the foot that the patient's come in contact with or has just been selected out and maybe not actually pathogenic. So, but I like Dr. Gilfus's input, something, a one drug regimen, easy in the outpatient setting and things like that.
Oh yeah, for sure. I think that definitely would have been a good option. Um, and like you said, stop the dapto. Reasons why, like just for our understanding, for reasons why these other ones wouldn't be effective, just so we can talk about those. A wouldn't be the best option just because we know that combination therapy is recommended, as the guidelines say. For something like this, like a simple skin and soft tissue infection, it may be the case of you might be able to get away with it, but generally not recommended. Ceftazidime monotherapy wouldn't be great, even though it says susceptible. It wouldn't be great just because, as we know, once carbapenem resistance is found in an Acinetobacter isolate, it's likely to be resistant to any single agent. And then D, it was susceptible to ceftazidime avibactam, but even though it was susceptible in vitro, there's actually no clinical data for using Avi-Cas in crab infections. So that wouldn't be a good option. So yeah, that is really all I have. Are there any questions or thoughts from the group?
Just gonna say, I kind of agree with Jess's point that, this is a superficial wound culture, skin soft tissue infection. A lot of cases, we choose not to target it, right? And you would just kind of ignore the isolation of crab.
Yeah, I totally agree. I think it's definitely like in this specific patient, I think we opted to treat, but we definitely were going back and forth a lot. Like, does this need treated? Because like you said, it tends to be selected out, especially from someone like him who received like so much, like such a long course of antibiotics already. It does tend to get selected out. So I think with everything like that, not being able to get an MRI, not doing any bone debridement, I think is what like scared us into it. So we opted to treat just for like a short course too, since we didn't have those bone cultures to back up like a 6-week course. So yeah, but another sort of like interesting, like something that the guidelines mention that I thought is interesting is like, let's say that it was isolated from the bone, and it was like a severe osteo or something. Technically, like they are recommending that combination therapy, but they do say for prolonged durations like osteomyelitis, if the patient improves, you may be able to like discontinue one agent, at least if your other one is susceptible. So I don't know if you guys have like done that or had a case where you've been able to do that, or if you've just continued on the combination therapy for the full 6 weeks.
I can say that I've seen a crab isolate from like a bone infection, yet where I really felt it was like bone related. Although actually we might have had a joint patient that we elected to do the 2 treatment, mostly because I think they were single stage revision, no plans for a second stage. So we were trying to be really aggressive. I know that patient, because of like the difficulty of getting his regimen like approved by any SNF, he was pretty much in the hospital that entire time to complete his 6 weeks of therapy. And if I remember correctly, we went with the Unison and the minocycline for him.
Yeah, that's usually our go-to as well. I just thought it was interesting they added that caveat that you could potentially de-escalate, but I don't think I've ever done that yet.
Right. Yeah. Yeah. And like thinking of the like organism, uh, a lot of these patients, when you're isolating these organisms, is pretty serious. So having that conversation as well. Bone infections are a little bit different, or skin soft tissue, but a lot of times when I've seen this bug isolated, it's in someone who's been in the hospital quite a bit, and it's starting to the care is starting to be transitioned and things like that. It's a marker from an ID standpoint that it's time to start talking about our options.
Yeah, for sure. Well, thank you guys. I appreciate the participation and everyone's input.
For joining us today, and thank you for giving us such a good presentation to follow along with, Katie. We appreciate that.
Sorry about the slides, by the way.
Okay. Fine.